All right, good morning, everybody. It's 8 o'clock. We're going to get started with our Coplow rounds today on this lovely rainy morning. I'm Dr. Jamie Miller. I'm one of the staff pathologists here, and I'm going to get us started. Where's the PowerPoint? Okay, here we go. All right. First off, I got some tissues from a 12-year-old castrated quarter horse. So we've got some clinical pictures up here on the screen. Got right eye on this side, left eye on this side. The main concern that they were worried about was this mass here in the conjunctiva and kind of extending onto the cornea. They also submitted biopsy of the left lower eyelid from the lateral canthus, I believe trying to get a look at what this little mass here was here. And then I also have some tissues. I said the right lower eyelid was pigmented. It's a little bit blurry and shiny, and I believe this is maybe the lesion that they were trying to sample to give us. So we are going to take a look at some of these masses from this horse. So starting with that large conjunctival corneal mass on the left eye. Here. See. As I scroll around, we can see that there are multiple tissues on the side. It was submitted in multiple pieces. We've got some with conjunctival epithelium here with this low profile, a little bit hyperplastic. From this low power, we can see these big blue nodules. And this is lymphocytes forming lymphocytic nodules in the conjunctiva. As we scroll around, we can see more of that here. We can also see that the epithelium gets very thickened. You can also see some of this maybe light blue material in the substantia propria, and we'll take a look at that closer in just a minute. We also have pieces of peripheral superficial corneal stroma, and this is kind of where I'll go start looking at what is causing this mass effect here. So let's get closer to our corneal stroma. You can see our corneal stroma here. We've got corneal epithelium here. It's pretty hyperplastic. We've got a nice basal cell layer, and it progresses normally. But then we hit this area here, this mass lesion, where we start to get anastomosing cords and lobules of neoplastic epithelial cells. I'll just call them what they are. They start to wander off into the underlying stroma. So we've got stromal invasion. As we get closer, these cells are polygonal. They've got variably often indistinct cell borders. Round over nuclei, finely stippled to dispersed chromatin, prominent nucleoli here, 1 to 2, a little bit moderate anisocytosis and anisokaryosis, so variation in cell shape and nuclear size. Some of these cells in the center of these lobules have hypereosinophilic cytoplasm and kind of glassy, typical of squamous differentiation. We also got plenty of mitotic figures around. And then some of them at the center here, we start to get this lamellar eosinophilic material this one's kind of loosely forming a ball, but this would be consistent with keratin pearls, which we can sometimes see with this neoplasia. Here's another example here. So this is a nice example of squamous cell carcinoma. And then to address I'm looking for more of that blue stuff. There it is. So in the underlying stroma here, at least in the conjunctiva where we can see it a little bit better, this light blue stuff, we've got light blue undulant prominent basophilic elastin fibers. And so this is solar elastosis, which is indicative of an actinic change caused by UV radiation from sun exposure. And so this is an underlying factor for tumor development, especially for the squamous cell carcinomas and even the blood vessel tumor, so hemangiomas, hemangiosarcomas. So it was pretty severe in these pieces. So this was the left mass there, consistent with squamous cell carcinoma. The smaller mass that they took from the eyelid margin, it was kind of yellow looking. So we have haired skin here. Ooh, we're going to ignore that. And hopefully, if there's any problems, people online can let us know. So we have haired skin up here. We have our meibomian gland here, and our conjunctival epithelium is quite hyperplastic. Again, a little bit of lymphoid follicle formation here, and the mass effect is caused by this structure here, this cystic space that is lined. Closer. Ooh, there we go. By keratinizing stratified squamous epithelium, it's got nice polarity to it. So we've got a basal cell layer here, we got our squamous layer here. Every once in a while, we see this the stratum granulosum here and our cortium here, and then it leads to this thick accumulation of the eosinophilic lamellar material that's consistent with keratin. So this is just a benign follicular cyst. And no evidence of tumor here, but as with our other samples, we've got pretty severe solar elastosis here in the dermis. So definitely a predisposing factor at this site. And then lastly, from the right eye with the little pigmented lesion. Get all the things today. All right. So we have meibomian gland. It's probably a little bit hyperplastic. There's a bit more of it here, but kind of intermixed with it is this population of pigmented polygonal cells. Kind of surrounds the gland, and then they also start to infiltrate into the epithelium of the ducts of the gland here. So they're polygonal, indistinct cell borders, pretty moderately pigmented, round to oval nuclei, finely stippled chromatin, no real mitotic figures, but there is epithelial involvement. So I think he's got a benign melanocytic tumor as well, so melanocytoma here in the eyelid. And then as we continue to look at this hyperplastic meibomian gland in the ducts here, we have lovely cross sections of these arthropods, consistent with Demodex. So we have a thin chitinous exoskeleton. We've got some internal structures, digestive tracts, reproductive tracts. Go. Oh my goodness, sorry.
Oh my gosh.
Little jointed appendages, muscle. So very cute and adorable. These are often an incidental finding. Sometimes they can be associated with clinical disease, but oftentimes they're subclinical or incidental, and they're just fun to catch on section when we have them. So it's a horse with kind of multiple masses. Here. So the squamous cell carcinoma in the cornea and conjunctiva with that marked follicular lymphoplasmacytic conjunctivitis, lots of solar elastosis in all of the samples. So definitely predisposing factors that this horse could maybe develop more tumors in the future. So they should keep an eye on it. A little benign follicular cyst, and then a little eyelid melanocytoma that's sort of blending with some hyperplasia, causing a mass effect, and some incidental Demodex.
Where's the horse from?
The horse, Utah.
Okay.
From Utah. Yes.
How often do you see the melanocytic associated with glands? Because as soon as you show that, it's just going to be a pigmented meibomian gland.
Yeah, that's really unusual.
proliferation, so that caught me off guard.
Yeah,
I'm not sure I've ever seen one.
yeah, and the horse was cream colored as well, so it was a non-gray horse, which gray horses are kind of known for their melanocytic tumors. So prognosis is unclear, but it seemed like they got it all, so hopefully okay.
Not the Demodex associated melanocytoma.
All right. So, moving on. Next up, we've got the right eye from a 6-year-old Yorkshire Terrier mix. Female, intact. She originally presented, let's see, early December of last year. There was 3+ flare, fibrin, and hyphema, along with orbital swelling causing exophthalmos. And then about a month later, in January of this year, the exophthalmos had resolved. There was still 2+ flare and fibrin. And they did a head CT and they showed orbital cellulitis with likely posterior globe rupture. So they elected to take the globe. Other eye was normal, and they reported no glaucoma in this globe. So on hemisection of our globe, this one might look a little bit different. So we've got cornea here, and we just have some extra adnexal structure still attached. We still have some eyelids here, which accounts for the extra tissue still attached to the globe. All right, so we have our cornea here. It's a little bit thickened. It was cloudy. We don't really see an anterior chamber anymore. The lens is here. It's also cloudy. The globe is kind of shrunken and misshapen. So when it starts to get wrinkled like this, we start to think about thesis bulbi just from chronicity of the lesion going on. There's lots of hemorrhage in the globe. This is where the optic nerve is. Again, globe's pretty distorted. And then we have some white tissue along the back of the lens here in the vitreous that we will take a look at histologically. Upside down. Here we go. All right, so again, extra adnexal structures up here. Got some very nice like whisker hairs. Here is our cornea. Focus that any bit more. Our big lens in the center. You can still see our uveal tract. Looks like that white tissue that we were seeing grossly here is a balled up piece of retina. Lots of hemorrhage here in like the subretinal space. Here's our optic nerve, and again, wrinkling and kind of a shrunken, misshapen globe consistent with thesis bulbi. Lovely sinus hairs here in our lid, but I'm more concerned about what's going on in the globe. So here's our cornea here. We've got some hyperplasia of the epithelium. It's a little bit cellular. We've got some neutrophils and blood vessels coming in. Not surprising given what's going on here. As we walk around, we've got this fibrovascular tissue in front of the lens here. So we've got a pupillary fibrovascular membrane. As we walk back, we can see that we get some liquefaction to our lens epithelium, lots of hemorrhage. Got some more purpley pink stuff. Looks maybe similar to lens. We'll take a look at that. Here's our balled up retina and more of that fibrosis around the lens. So if we get a little bit closer. Here's a nice look at that chronic fibrovascular membrane, kind of lining the lens here. And if we follow the lens and the lens capsule around, we get to a point where we kind of lose it here. It gets a little bit discontinuous. We've got our lens epithelium here, and they kind of go away, and you pick them up over here. So there's evidence of lens capsule rupture. There's a little bit of inflammation in the uveal tract, some lymphocytes, plasma cells. Again, lots of hemorrhage. We can see our liquefaction of our lens fibers here. There's also evidence of intralenticular hemorrhage. So again, discontinuous lens capsule, letting the hemorrhage in. And if we look at some of this purple stuff back here, it looks very similar to our lens material. So we've got free lens fibers also in the subretinal space along with this hemorrhage, just corroborating our lens capsule rupture. And then our hemorrhage and fibrosis again continues around the lens. Here we've got evidence of chronic hemorrhage with the hemosiderin-laden macrophages. You can see our balled up retina. And then as we continue going along, we come across our culprit here. So kind of here in the choroid suprachoroidal space are these refractile foreign bodies consistent with plant material. And we've got a bunch of multinucleated giant cells trying to gobble them up. Cute and adorable. Let's see if I can. Oh, I don't even have to split the thing. Yes, very cute. Ooh, so there's your color therapy for today for me. So we've got plant foreign material. This was the ventral aspect of the globe. So consistent with penetrating traumatic event, something that came in from the oral cavity, like a migrating grasshopper even, causing the issues in the dog. I will say that we did say that there didn't appear to be a lot of inflammation outside the globe, despite what their CT said. But we just made that comment to them so they knew that we weren't seeing that in our histologic section.
Can you see it person?
No, it's oftentimes we don't catch the globe rupture sites because they can be really small. We can have the foreign material. I imagine it would have been, like somewhere here-ish.
They can be less than a diameter and
Like
less than a millimeter in diameter, so they can be really hard to see.
Yeah. So it was sort of a lucky section. We can have some clues because one of the reasons that we sometimes will leave the extraocular tissues on is that sometimes they get adhered to the globe because of fibrosis and stuff around where the puncture site may be. So if there's a place that we can maybe think that might be suspicious for a site, we'll definitely try to sample it in. Most of the times we're kind of cutting a little blind and hope for the best with our sections.
It's interesting that the lens capsule rupture site was opposite where the plant was.
Yeah.
Who knows why?
Just yeah. Yeah.
Could be.
So overall, basically penetrating trauma with the plant foreign body, and lots of things that go with that. Thesis bulbi, intraocular hemorrhage, lens capsule rupture, lots of membrane formation, retinal detachment and such. So
Where was this dog from?
I believe this one was actually from Pennsylvania. So maybe not a classic location for migrating grasshopper, which is usually like California, but apparently they're kind of everywhere. So who knows what this dog was running around doing. All right, I'm gonna pass it over. Yes, okay. Okay. So this first case is really, really cool. They're all really, really cool. But let's see.
I'm Megan, by the way, one of the clinical pathology, or the, not, oh my goodness, I'm off to a great start. One of the staff pathologists at Coplow. All right. So this is a 10-year-old spayed female Chihuahua mix. She has a long history. Basically initially presented with retinal detachment that I believe initially responded to steroid therapy. But basically eventually did not respond to steroid therapy. Things got worse. Developed signs of uveitis in both eyes. Glaucoma, eventually one eye started to go thecal. Basically, these are the summary of kind of how that progressed. Ultimately, this patient had been on significant immunomodulatory or immunosuppressive therapy by the time of enucleation. So they initially were trying steroids, and then she was also started on mycophenolate at one point. Let's see. She also eventually developed GI upset, which we'll update more on later. And that's, I think, all I want to share initially. So we ended up with both eyes, the left and the right eye. We didn't have a gross photo, so I pulled a gross photo from a case that is maybe kind of similar from recent files. So this is a hemisected view of a globe, not the patient's globe that I'm showing, but maybe just some gross features to think of. Mainly that we have some exudate in the vitreous here. The vitreous is a little bit cloudy. And there's kind of a white tan carpet over the ciliary body and maybe retinal surfaces, and maybe sort of a partial or multifocal retinal detachment. So like this thin structure here is likely retina. So that's kind of all I want to show on the gross, and we're going to go ahead and go straight to histology. All right. I'm actually going to just quickly show off the difference between the two globes on an attempted subgross here, but then we're going to focus in on one of the globes. So this is the right globe. So it's the one that was starting to get a little bit thecal. It's kind of also a little bit covered in dust and so forth. If that helps at all, that does help. All right, it's a little bit hard to balance it because it's kind of at the edge of the slide, but you can see that this globe is a little bit smaller with a wrinkled collagenous tunic. The sclera is kind of all wrinkly here. And there's a little bit of intraocular fibrosis, which is causing that. So these are features of kind of thesis bulbi. And there's also too much purple in this. So there was an endophthalmitis similar to the eye that we're going to look at a little bit more than that. And then compare it to the subgross of the left globe, which is not really thecal. We're going to find a place and stick with it so it's not as wobbly. And here in the posterior segment, we can see a little bit of hemorrhage and too much purple kind of in and under the retina. So similar to the representative gross photo that we had, a little bit of an endophthalmitis and some degree of retinal detachment. All right. So we do have a little bit of endophthalmitis and hemorrhage in pretty much every chamber. And we have some posterior synechia here. The iris is plastered down onto the lens. But we're going to quickly migrate back and pay more attention to the posterior segment. All of this pink stuff here is basically just high protein fluid in the vitreal chamber, along with the hemorrhage, which is bright red. And then there are cells, which are the purple, and we'll look closer at those cells. But we've got more of the endophthalmitis kind of closer to the optic nerve head here with these purple areas. We can see from even lower magnification, the cupping and atrophy of the optic nerves. This globe did have glaucoma and some more clumps of this inflammatory exudate in kind of the posterior vitreous and or subretinal space, and kind of carpeting the epichoroidal surface in some areas. So let's see, we're going to drop in right here in the midst of the vitreous. So the purple is still the inflammatory cells, but as we get closer to this area here, there's this weird like pinkish stuff. Looking even closer, it turns out the reason why it looks kind of funny there is because we have all sorts of microorganisms here. Ooh. Look at these. Oh, thank you, Gillian. So we have over here our inflammatory cells. So these actually are cells belonging to the patient. So neutrophils and probably some macrophages. And then these are infectious microorganisms. They are poorly staining. Here we have a lovely example of pseudohyphae. So we have these kind of little restrictions of these sort of oval-shaped structures forming a little chain or so. There are also examples of hyphae, so basically true hyphae. We have relatively parallel walls and occasional septation. And then there are also examples of these yeast-type structures. So we have just oval guys kind of hanging out by themselves. So pseudohyphae, hyphae, and yeast all together, which does suggest a particular type of fungus. And we have a good number of these kind of clumping up in the vitreous. Just really good examples of the morphology in this particular eye. Oh, I could go in closer, I suppose. And I could probably go in closer and stop for a bit because motoring around doesn't really help. All right, there it is. So that's really interesting. And you might wonder, we are going to skip to the other eye really quick if we found any of those similar organisms in the other eye. Because I will say that if we do see fungus inside an eye, it is possible to get a local extension from a local anatomic structure. Unlikely when there isn't a lot of orbital disease. It is possible to get contaminated penetrating trauma, and that's why you get fungus in your eye. There's no evidence of trauma necessarily in our sections. But when we see fungus in the eye, especially in the posterior segment, we worry about a systemic mycosis. Did this fungus get to the eye hematogenously? And then that's especially true if we have bilateral endophthalmitis or uveitis. And if I was smart, I would have put a dot on this slide, but I wasn't. So paralysis of the marking pen hand, as Howard Steinberg would say. But I'm pretty sure the thing I'm trying to show you is here. And if I spend some time looking for it and don't find it, we'll move on. So this is the right eye, the kind of more thesical eye. You can see a similar pyogranulomatous endophthalmitis here. And you really had to look to find anything in this eye. Yeah, I think that's what I'm looking for there. But there are maybe some instances of similar kind of oval-shaped structures amongst the inflammatory cells. It's debatable. I do believe, hang on one second, we do have a PAS for fungus, which we could have just switched to right away. And then we can prove it to you that camera is freaking out. All right, here we go. Oh, because I'm on the wrong objective. All right. Oh, I did do a dot here. Thank you, past me.
Yeah.
There we go. Whoops, that was as close as we could go. All right. So here we are. We have a little friend. It looks like he's budding. That's PS for fungus, so that highlights the walls of fungus, this magenta pink. You can see that there's also some like staining of the carbohydrate, like bits in macrophage cytoplasm, which happens too, but this is our fungal organism. So basically there's similar fungus in both eyes, less so in the right eye and more evident in the left eye. We're definitely worried about systemic mycosis in this case. And you may have had a specific type of fungus in mind based on the morphology of having hyphae, pseudohyphae, and yeast types all in the same place, which is Candida. So Candida organisms are the ones that tend to do that. So that would be a pretty unusual diagnosis to make for an endophthalmitis, though. And it can be kind of difficult to definitively speciate a fungus based on histomorphology alone. But we assume that this is the same fungus, and at least Candida is our top sort of suspicion, despite it being a rare cause of endophthalmitis. So ultimately, the rest of the stuff to reveal for this patient is that she developed a draining abscess in her mouth. And she also had severe gastrointestinal upset over time. It was to the point where she was sort of vomiting daily, is what was described to us. So really bad GI signs. We did end up doing a panfungal PCR to see if we could get confirmation of a species in this case, because this is such a rare diagnosis. Oh, hey. And that was on the left eye, which had more organisms, and it was 100% match for Candida albicans. So this is pretty much a, clear cut, I guess, diagnosis of, oh, don't move it. Don't move it.
Did you say narrow-based budding?
I did not specifically say narrow-based budding, but yeah, that would be an example of narrow-based budding.
Okay, we don't usually see that.
That, okay. So that, yeah, I mean, that's part of the reason why the pan-fungal PCR was nice to have. But yeah, okay, we'll stay back on that.
Kelsey Brakel pipes up in the chat and asks, do you think the fungal organisms are viable? On H&E, it looked like there wasn't any staining material inside the walls.
This is a good
And
question.
then also followed up with Gasper's comments, narrow-based budding or pseudo.
Ah, yeah. Or like a pseudohyphae to be.
Produce
It
them, they
is,
kind of.
yeah.
Some of them look like they had little nuclei or something.
Yeah.
If they form
They
shapes
look
like
small.
that, so that's just like lines.
Yeah, okay.
It's a pseudohypha in potentia.
Yeah.
That's right. I sounded fancy there if I didn't trip over the word slightly.
Yeah,
Yeah, some of them have what look like nuclei, but yeah, it's interesting that a lot of them seem sort of empty. But yeah, like these guys seem to have viable stuff inside them, the sort of basophilic nuclear material, maybe. These guys have sort of shrunken eosinophilic stuff, which does kind of look dead. So yeah, some of them are probably viable. Maybe some of them are non-viable, which is interesting given that, as far as I know, the patient wasn't being treated with antifungals by the time of enucleation. As far as I know. So, go ahead.
Do you have a PAS stain of this lobe?
I don't,
Okay.
because they're right here. I don't know. Go ahead.
So somebody else piped up and said Candida albicans yeast will be round, so anything oval will be the beginning of a pseudohypha.
Ah, there you go.
And Brakel pipes up again and just says, just curious if the non-viable organisms are PAS positive.
We had a discussion about this earlier. Yeah.
We don't know, Brakel, maybe we can report later.
Yeah, we'll throw a PAS on this and we'll let you know.
And Leandro wants us to comment on something, which I believe you're getting to, but you're beating around the bush.
Okay,
Yeah.
all right, let's get to it. Most likely this was originally gastrointestinal candida that disseminated systemically. Candida is a like regular organism in the gastrointestinal flora of our patients or fauna. So it's sort of expected to be there, but there are conditions where it can overgrow. Presumably, the immunosuppression in this patient contributed to this to some extent. Being on steroids and mycophenolate was probably part of why the candida disseminated the way it did and overgrew in the GI tract. It's unclear exactly what the steps of pathogenesis were in terms of like how this case progressed. Endophthalmitis from Candida is super rare. We have diagnosed at least, like, there have been suspected cases, but they're extremely rare. And then we have a couple of suspected cases in the cornea, but, you know, usually not endophthalmitis. In the literature, in both kind of veterinary patients and human patients, there's like a bunch of risk factors for disseminated candidiasis. Immunosuppression is definitely one of them. Diabetes, you know, things like that. Like chronic antimicrobial use, you know, things that cause like dysbiosis and immunosuppression are kind of what we're thinking about here. So yeah, I also learned the word candidemia during this case. What a fun word that is, candidemia. So anyway, that is this case, which is a really, really unusual type of fungal organisms, which we almost never see inside the eye. Did that answer the question from?
I've got a few cases in rabbits that were given dexamethasone and
A few cases in rabbits.
In their eyes?
widely disseminated. There's not limited to any tissue, it's everywhere.
Yeah.
Used in the glomerular capillaries and stuff.
Oh, that renal
Oh.
thrush.
Renal thrush. Ugh. Candidemia, renal thrush, really fun words. Yeah. So yeah, to repeat, David Gasper was saying that he's seen it in disseminated candidiasis in rabbits administered dexamethasone. And yeah, I mean, it has been reported to sort of disseminate from the skin or GI especially, which kind of makes sense. That's where Candida might live. I mean, it's also been reported in immunocompetent patients for what it's worth, but there are certain risk factors that make it more likely. Did that answer all the questions? I see more commentary popping up. Okay, all right.
No.
I mean, yes, you.
Yeah, it's a really cool case.
No.
I mean, it's not cool for the patient. Oh, I should say, speaking of not cool for the patient, though, she is responding to antifungals and doing better at last check. So, yeah, I sometimes feel slightly guilty about getting very excited about cool histologic lesions that aren't like fun for the patient, but she's responding well to therapy. Okay.
You know what's happened in people, candidemia? I
Yes.
think so. Okay.
Descended candidiasis happens in people. And everybody is excited about that.
Yeah.
Tonsillectomy invasion.
Tonsillectomy
It
invasion.
happened to me.
You happened to you?
Candida
No.
stuff, Candida, premium.
Oh, no. Candidemia.
Ooh. Oh yeah, here you go. Okay. All right, second case. Maybe you'll get to do some cases today, Kelsey.
No worries at all. These are good cases.
So this is a 14-year-old neutered male poodle. So the right eye is normal and the left eye is blind, with corneal ulceration, and glaucoma. And presumably it was probably kind of hard to see inside the globe. That's kind of all the history I got. So once again, I have representative photos in this case, and not necessarily the photo of this case. So these were both from our portfolio of a similar condition in dogs. I wanted to pull both these photos because they each have features that I kind of like. So especially in this photo on the left, you can see that there's evidence of a cataract. The lens is kind of cloudy. And then the iris kind of looks like it's wearing eyeliner. It's got this kind of white carpet, yeah, white eyeliner. It's got this kind of carpet over it, and also on the ciliary body surface, kind of outlining the uveal tract, which I think you can see best on the left. You can still kind of see that on the right as well, with this carpeting of the uveal surfaces, especially visible anteriorly. The additional thing that this one has that's kind of like our case that I thought was interesting is we have this bulge at the limbus, where you kind of can't really make out like an obvious sclera. There's maybe something weird going on here. And our case also had a limbal bulge like that. So let's go to histology. Oh, very hard to get a good subgross going. So you can see that the limbus here is looking a little weirdly purple, and we're going to look at that closer. Otherwise, it just looks like a fairly purple eye, and I'm just going to drop straight into higher magnification because I want to. All right, so a little bit higher magnification, we can again see like all of these cells that are invading the limbal sclera, and the collagen that's actually supposed to be there of the cornea / sclera is kind of lost. We'll look at that closer. Right here over the anterior uvea, we can see that the carpet that would have been kind of white tan grossly is now purple, so lots of cells carpeting the uveal surfaces and also infiltrating the uveal stroma. See a similar sort of a carpet here. It's a very fuzzy looking iris and ciliary body. And in this case, the carpet is also extending onto the epichoroidal surface. And we can't really make out much of a retina. We'll look closer. There's kind of a slight stubbing here that's somewhat recognizable, but mostly the retina is pretty necrotic and detached. From low magnification, we can see these lovely asteroid bodies, which we'll take a look at closer. And we can also see this pink halo near this carpety area, and we'll take a look at that closer too. This might not have been the best place to drop in on for other reasons, but. So the uveal stroma itself more or less ends like way over here. If you don't believe me, you can nudge slightly that way. So kind of uvea is here. And then all this stuff on top of it from like here to here is fibrovascular membrane. You can see these little tiny vessels here and there. That's infiltrated pretty heavily by inflammatory cells, lymphocytes, plasma cells, macrophages. And then on top of that membrane, there's this multi-layer carpet of epithelioid macrophages. So these are macrophages here, and then they're associated with neutrophils. So this is our epithelioid macrophage carpet, which is a key diagnostic feature of this condition. I dropped it on this little extra slice specifically because here are these little purple bodies. So these are asteroid bodies. We had an asteroid hyalosis in this case. And I thought that there was a thing that I could show you here. Wait for it, wait for it. I do have a PAS actually. We'll go to the PAS and do that later. That's a good idea. All right, we'll do that bit later. So we can see these asteroid bodies embedded around here. They're a little bit too far forward for the vitreous, but we'll see that better later. We're gonna nudge ourselves back over this way. There we go. So all that pink stuff that was forming a halo is actually these globules of extracellular protein. And they're both free in the vitreous / posterior chamber and being phagocytized by these cells next door. So it's very interesting protein. And if we want to figure out where that protein came from, let's walk over to the lens. So if we drop in on the lens capsule here, you can see that the capsule is looking kind of fuzzy almost. So we have a similar globular protein that's kind of coming out of the lens capsule and again being phagocytized by the cells that are next door. And so this is leakage of lens protein through the capsule. And we're getting a response to that lens protein. A really interesting feature of this case that we don't see all the time is that as we walk along this lens capsule, on top of seeing the protein kind of bulging out like this as a solar flare effect. Wait, we're going to find it. I like likening it to a solar flare just because. All right. The lens is kind of weirdly sectioned, so it's hard to find exactly where like everything is oriented. But here, for example, we can see that the lens capsule itself is frayed. And the inflammatory cells are lining that frayed edge and phagocytizing lens protein again. The capsule itself also has a really unusual look here. It's kind of got this stippled, more brightly eosinophilic stain through it, which is kind of unusual.
Brakel asks, okay, never
Go
mind.
ahead. Oh,
You answered it.
Oh, I did?
She asked if any of that could have been lens capsule itself. So I think
Could be.
where Megan first started was more posterior lens capsule, which should have been much thinner there than it was. So I suspect that some of that at least is not just lens capsule, but
yeah, like this here, I would imagine that this is more likely leaked protein from here to here, and because we kind of have a distinct capsule from that. However, yeah, it kind of just blends in, and the capsule itself is basically being decompensated, it looks like in this case, and nibbled on. So there are areas where it's a little bit less clear, I would say. Agreed on that. So yeah, that's really cool. And what I think this demonstrates is that to some extent, the inflammatory cells themselves may be releasing like matrix metalloproteinases, things like that may be kind of breaking down the lens capsule a bit. Or it shows that like the lens proteins can kind of leak out through the capsule with our like phacolytic uveitic processes, which is kind of cool. I think more often we blame, so like if we see a spontaneous lens capsule rupture, and like in the context of really severe inflammation, it's more often like fungal cases where we have fungal hyphae that are invading the capsule. And those guys may be destabilizing the capsule, but I do think that there may be some cases where just inflammation alone may be kind of involved. But anyway, that's kind of speculative. And just some neat findings. Go ahead.
I think I also speculated when Megan showed me this case that if enough lens protein was leaking through the capsule all at once, would that destabilize the structure of the lens capsule just because of how much liquefied stuff is in its substance?
Yeah, I think that's an interesting thought too. And the way that there's kind of that like stippled, like more brightly eosinophilic stain through the lens capsule is really interesting in this case. Yeah, just cool. Cool things to think about. Before we move on to our PAS, we have this area of the limbal sclera that I was so interested in earlier. And you can see in this case that there is a break in Descemet's membrane. So here's one end and here's the other. And then there's basically no normal collagen through here. It's kind of just replaced by fibrovascular tissue. And then there are pockets of inflammatory cells through that. And if we look amongst the inflammatory cells sometimes, we have the eosinophilic protein again. So there's actually lens protein leaking out through this gap in the limbal sclera. And this site is either basically a site of decompensation of the collagenous tunic associated with the inflammation itself, essentially a draining tract is what this may represent. Or it could be a site of penetrating trauma. And it would be difficult for us to be sure one way or the other. But yeah, either way, lens protein was basically leaking out through this gap, which is pretty interesting. I think that's everything I want to show you on the H&E. We'll briefly switch to the PAS because it's fun. So the PAS highlights the basement membrane of Decimay is really nice. And it also highlights the asteroid bodies, which are so pretty in pink. And you can see them wrapping around the iris embedded in the pre-iridoid fibrovascular membrane. So this is one of the few ways we can be positive about anterior vitreal prolapse by histologic evaluation. This vitreous definitely prolapsed anteriorly in this case, which is kind of cool. And also the asteroid bodies just look pretty.
And lens protein typically does not stain very brightly with a PAS stain.
Yeah, and I'll show you that. So here's the asteroid bodies being all bright and pretty, and then that area with the lovely kind of ribbon of lens protein, they look less bright pink. So yeah, actually there's a nice asteroid body to compare. Well, I don't know if that's asteroid body. There's nice asteroid bodies next to lens protein, sort of. There we go. Now they're in the same field. Lens protein, asteroid bodies. All right, I think that's everything that I wanted to show for this case. I know we had it last time as well, but you know, nothing wrong with a review of asynchronous or asymmetric uveitis, which is presumably a sort of hypersensitivity or phacoanaphylaxis of sorts, basically a really severe lens-induced process. And the reason why we make a specific diagnosis for this is that there is potential risk to the other eye with potential development of severe uveitis down the road, particularly if the other eye is cataract. So that's it. I'm going to move because I've taken up way too much time.
Lesion is somewhat common for asynchronous uveitis.
Yeah, there are cases, I didn't really focus on the retina, but it did get pretty necrotic too. And yeah, you can get like really severe uveal necrosis. And as Kelsey points out, sometimes limbal scleral necrosis like this in cases. We do tend to get more severe in diabetic cases. Mm-hmm. But yeah, it's not uncommon to see like that limbal sclera lesion in particular in these really severe lens-induced uveitis. Okay, I'm gonna move. I took up way too much time.
Brakel asks, so Brakel was commenting about how liquefied lens protein gets through a basement membrane that's intact. So there's a bit of discussion there. And then asks, is it fenestrated like the kidney glomerular basement membrane? I have no idea.
No.
I doubt it.
Mm.
Okay.
Yeah. Okay.
The consensus is no.
Yeah, especially since it doesn't happen with normal lenses.
And it doesn't happen with cataract. When you already have liquefaction with the lens matrix, it should leak out then too. So this is a different. So I agree with Dr. B.
Okay.
The other. I'm always disagreeing.
The other KB.
We have to refer to them as Brakel, and well, here we call Kelsey Brown Kelsey.
Pretty cool.
I'm pretty used to it. I feel like it's a very common name amongst my generation. So all right. I think I have time to get through this case. It's pretty short. So this case is a 2.5-year approximately male castrated Greater Swiss mountain dog. And let's see. The history we got was for, let's see, duration of problem was less than a month. 3 raised white masses were noted. Let's see, 2 weeks prior to when this globe was removed. And then at removal, they said more raised pink white lesions were present with progressive inflammation. So the clinician provided us several really beautiful photos showing these kind of coalescing masses within the anterior chamber, kind of obscuring the iris at this point. The clinician also noted that the dog had been diagnosed with irritable bowel syndrome, and there was some degree of concern for prototheca. They also said other differentials include cancer versus fungus versus who knows, which I appreciate. I have felt that way before. So grossly, here's our hemisected view of the globe, and we can see this mass lesion kind of bulging into the anterior chamber. It seems to be involving the kind of base of the iris. We can still see some of the iris here, as well as creeping into the ciliary body. There's also these little like white tufts that are hanging out kind of in the vitreous / posterior chamber. Rest of the globe is relatively unremarkable. Optic nerve head looks great. This globe did not have glaucoma per the clinician. All right, so let's move to histo. I'll actually remember to do the subgrowths this time, because I always forget. I'll hold it there. I have very shaky hands, so I try not to touch the slide. All right, so cornea is up top, looks pretty good. We have one little iris leaflet in our ciliary body on this side, which look relatively unremarkable. And then here's the mass itself. It's very purple. And as we saw grossly, it kind of is at the base of the iris involving the ciliary body. And then we have at least one of those little like tufts of cells hanging out in the vitreous here that we saw grossly. And then everything else, so optic nerve head, retina, lens look relatively unremarkable. So when we pop this on the stand, probably won't go over those in great depth. If I can focus, there we go. Okay, so this globe's been rotated. So now the cornea is going to be on the right, posterior segment is going to be as I move left. And as we saw at the subgrowths, everything's somewhat unremarkable besides kind of that mass effect. So remaining iris leaflet, cornea itself looks pretty good. So we'll go ahead and actually address the elephant in the room, which is this mass. Okay, if I can, there we go. So here's kind of the overview of this mass. And it is kind of protruding into the anterior chamber as we saw, and infiltrating, expanding ciliary body and the base of the iris stroma. It's pretty well demarcated. There's no capsule associated. It's quite densely cellular. There's kind of these little coalescing areas of necrosis throughout the mass, but most of it we can see still looks pretty viable. Ew, let's get a little closer. All right, so we have a pretty homogeneous population of cells. So spoiler, this is a neoplasm. And these cells are kind of somewhat indistinct. It's hard to see their borders at least, but they have this kind of vague spindle appearance. Some areas are kind of just making these densely cellular areas without much pattern. And some areas are making these very distinct, beautiful rosettes. Kind of move around and show more of those. There's quite a few in here. And if we're going to get really fancy with kind of the board's terminology, we could say that they're forming Homer Wright and Flexner Wintersteiner rosettes. Quite a few of them. And then in some areas they do also, let's see if I can find a good example, kind of palisade around vessels. Like I'm not finding a great example. There's like a little vessel here, and they kind of line up around the vessel. So we do have some pseudo rosettes in here as well, where they kind of look like a rosette, but it's around a little capillary, so it's not a true rosette. There's a lot of gatekeeping in the rosette community. So looking at the finer features of these cells, yeah, again, they don't have very distinct borders, a very scant amount of cytoplasm. So we can see a little bit of eosinophilic cytoplasm, but it's a lot of nucleus mostly. Nuclei are round to oval, pretty coarse chromatin. Sometimes if we squint, we can make out one or two pretty prominent nucleoli. And there are mitoses amongst this population. Not high, it was like 5 mitoses, I think, per 10 high power fields, but they're there. There's one right there. And let's see, I feel like I had some other features to show off. Yeah, in some areas, this might be an area of necrosis, but in some areas there is kind of like this very kind of fine, loose stroma that they're associated with. This might be areas like that. And yeah, here's a little bit more of it right here. It's kind of loose stroma. And there's one really like beautiful area where these cells kind of line up here, make this really pretty structure.
Looks
Yeah.
like retina.
It looks like
It
retina,
actually-
which is
you know
kind
what?
of cool.
It actually looks like embryonic retina,
Mhm.
like developing
Mhm,
retina. That's
it
really
does.
cool.
Isn't that beautiful?
Yeah. Wow.
All right. Those are kind of the fine features there. I'll quickly show those little kind of floaters of tissue that we saw grossly. Here they are, and likely just more neoplastic cells. They're kind of bunched up, but they still kind of have similar scant cytoplasm, indistinct borders, kind of just hanging out there in the posterior chamber and the vitreous. And honestly, for sake of time, I won't go over anything else. There's no glaucoma. Everything else looks really, really good. It really is just this neoplasm. So these features here, and as Dr. Shaw kind of alluded to, we have kind of this embryonic population of cells. So this look, making the rosettes, the pseudo-rosettes, its confinement to the uveal tract is most consistent with a primitive neuroectodermal tumor. In this location, most consistent with the medulloepithelioma. Let me move over to the diagnosis section, which here it is. So I feel like these always kind of intimidate me a little bit because the nomenclature is a little bit complicated, especially in the human literature. I feel like there's been a lot of divergence of these terms. But to put it simply, these primitive neuroectodermal tumors, as the name implies, originate from primitive neuroectoderm, which are going to be cells that are lining the inside of the optic cup during embryogenesis. And those cells can be destined to become structures of the retina and the ciliary body, specifically the ciliary body epithelium. And they can sometimes look more differentiated to look more like epithelium. In this case, they were quite undifferentiated. So really is emphasizing the primitive portion of this tumor. And when they are in the ciliary body, typically that's most consistent with medulloepithelioma. The prognosis for these is a little bit vague in dogs. There are reports of metastatic behavior. However, there are quite a few where enucleation appears to be curative, and that long-term follow-up, they don't have any metastases. So it is possible this one could metastasize, but it's also possible that it won't be a problem for this dog. Trying to think if I have anything else. No, go for it. Do you have anything?
Dr. D pipes up in the chat and says that the tentacle-like extensions are also telling. I'm assuming you mean the little blobs of cells that are floating around in the
Mhm.
globe. I think that's what he means.
That
Also, I was
tentacle.
gonna say that feature of little blobs floating around the globe is so similar to retinoblastoma in people,
That's
actually,
interesting.
in
I didn't know
kids.
These little guys.
So yeah, and the fact that one
Interesting,
area
too.
looks so much like primitive retina, this is
Mhm.
such an interesting tumor. Animals, I mean, there are very few reports of true retinoblastoma in animals, so I think it's
Mhm.
exceedingly rare. But man, this one, you could make a case for it, except
I'd
its
be too
location.
scared too.
Yeah, except its primary location is not associated with the
Mhm.
retina.
Mhm.
But anyway, this is a really cool
Yeah.
case. Wow.
Yeah, it's
Really
beautiful.
neat. Yeah.
Cool.
Cool.
Cool. All right. So yeah, good news and no prototheca. So good news for the clinician too and the dog.
Oh, and also this dog was quite young, right?
Yes. Oh, that's the
Yeah.
other point. Yeah,
So,
this
yeah.
dog was 3.5 years old.
Yeah, so
this is definitely reported in young dogs.
cool. All right, thanks everyone.
Cool.
Have a good Wednesday.
There's the better too. There, it's not showing.